Yes.
Good morning, Dr. Dinesh. Please start.
Yes. So good morning, everyone. And today is very important day. And wish you a very happy International Women's Day. And today we have all speaker and panelists. Both are the women. And this is a very special moment for all of us. And today's module topic is the acute liver failure in pediatric and neonatal. And our speaker for that is Dr. ARTI PAWARIA. And without wasting much time, I would request our president, Dr. Ajay Gupta sir, say two few words, and then we'll start.
Thank you, Dr. Dinesh. Today is the seventh session in this Master E-classes in Pediatric Gastroenterology. We have eminent speaker, Dr. ARTI PAWARIA, and we have eminent chairpersons, Dr. Anjali Bansal, who was the past president of Punjab Indian Academy of Pediatrics, and Dr. Seema Rai, head of the department at Freethcourt Medical College. And we have an expert, Dr. Karunesh, who is a senior gastroenterologist at Apollo Hospital, Delhi. And our coordinator, Shamina, who is doing a wonderful job and is coordinating with all the panelists as well as speakers. I request Dr. Shamina to please introduce and then start the session. We welcome Dr. Alok Bhandari, sir, Treasurer, Central IAP, National Treasurer, Central IAP, and request Dr. Alok Bhandari, sir, to please say a few
Sir, before going to that, sir, Dr. Bhandari, good morning.
Sir, please unmute. Unmute, sir.
Well, good morning, friends. As I was
sir, 1 minute, sir. Today is your birthday also, so wish you a very happy birthday, sir.
Thank you, dear friends.
Happy birthday, sir. Happy birthday.
Happy birthday, sir.
Thank you, Ji. Thank you.
Good birthday on Women's Day. Good.
So I was just thinking the COVID times taught us how to go online teaching and classes, and I'm happy to share with you that IAP Delhi took this initiative of online teaching classes, and ever since last 4 years and so things have improved at IAP Delhi. We have very energetic youngsters who came into active working mode, and IAP Delhi is consistently spreading this knowledge through our weekly classes. They are a big success and in big demand, not only from northern India, all over India, even South India, East India. I get a very good feedback about our classes, and for last 2 years, the credit goes to Dr. Ajay Gupta and Shyam Meena, who have been actively pursuing with this activity with full passion. And my best wishes to all of you, and looking forward to a great session by Dr. Aarti, who has been passionately involved in GI related issues for IAP Delhi. Welcome all and happy learning. Thank you.
Thank you, sir. Now I request Dr. Meena, sir, to please start and introduce all the speakers and chairpersons.
Hello, very good morning to all. Very warm welcome on this platform. And I would like to first thanks to IAP Delhi to give me this opportunity to hold this important classes on Sunday morning to awareness of related to GI and hepatology in our dear pediatrics colleagues. Today we have the eminent faculty or speaker, Dr. ARTI PAWARIA. She is well-known faculty in pediatric hepatology field. Dr. Pawaria currently working as a chief hepatologist and transplant physician in Reliance Foundation Hospital, Mumbai. And earlier she did the DM from the pediatric hepatology department, ILBS. Over to Dr. Aarti.
Thank you very much. At the outset, thank the Central IAP, Delhi IAP, and I remember how Dr. Sham used to tell we should start something like this, almost a year back. And he has very tirelessly worked. I'm very happy that the entire team has come forward to support this kind of learning. When we do it in silos, when you do it on the public platform, it is extremely valuable. And look at the number of participants who have joined in. I think this was a great learning platform. And I would like to start today.
I request our chairpersons, Dr. Anjali and Dr. Seema Rai, ma'am, please say a few words on this.
Thank you, sir, for the opportunity you have given to us
being from a very small branch and from the peripheries, we are still very humble to participate in such events conducted by IAP. And I must say that IAP Delhi is doing a very good job in doing these activities. And we are hopeful for participating in the more future activities. And I wish Dr. Arti to continue with the session and hope we'll have a good learning.
Dr. Seema, ma'am, please unmute.
Yeah, thank you for the opportunity. I think we will not take much time. It's already 9:05, so we'll over to Dr. Arti. We are
Thank
eager to hear from her. Yeah,
Thank you.
thank you. Thank you.
Please start, ma'am. Please start sharing your screen.
I'll start sharing my screen. Is the screen visible?
No, not
Yes.
Yes, ma'am. Please
Yes.
make it full screen.
Yeah.
Yes, ma'am. Please start.
I'll start, and I was given the topic pediatric and neonatal acute liver failure. I will first touch upon pediatric and then go into this other segment of neonatal. I purposely made it little separate because to understand the pathophysiology of it and the approach to its management is extremely important. Because pediatric acute liver failure comes to us as a much more common problem starting from our OPDs, we move to them first. So, what is the challenge in pediatric acute liver failure is that first we have to identify that there is liver failure and then to see whether it is treatable, whether it was preventable, and so we can prevent it future episodes or in other children, and if transplant is needed, but we must make sure that it has to be transplanted only if there is no other way of survival. So this, I always want to say that whenever we have a child who is liver failure, we should not say go to a transplant center. We should say go to a liver failure management unit or a dedicated liver unit. As you would see, there is a stark difference in the way India versus the West does. In our country, still, acute viral hepatitis is the most common. The hepatitis A and E still remains, as compared to the West, where of course paracetamol and drug-induced and other metabolic liver diseases come much higher in population. In our country, we are still struggling with hepatitis A, hepatitis E, Wilson's, autoimmune hepatitis presenting at cases like this. So this is what I meant, that we should have a comprehensive pediatric liver center which does the best of the management in both transplant and non-transplant. This is the edge where we have to pull those children, and it is, believe me, it is so worth saving those children who come to your center as needing a transplant, and you save them without a transplant. You give them a life which is absolutely normal post that. So when we approach a child with acute liver failure, the first question is there a liver failure? Say yes or no to that. If there is a liver failure, irrespective of how the child is appearing to you at that very moment, our approach must change. The second is, what is the type of disease process? Is it hyperacute? This is when the jaundice to encephalopathy interval is less than 7 days. Acute, subacute, acute, and chronic. So as we go probably by the e-learning modules, we'll have many of them, but this is very important to identify in the beginning. So my history is very, very important. Second, identify the most common and treatable etiologies first. Again, the viral, because they're most common. Wilson's, autoimmune come very first in the segment to say, or what are we dealing with? By definition, acute liver failure in children is defined as those children with no known evidence of chronic liver disease, with biochemical evidence of acute liver injury and a hepatic-based coagulopathy, which is defined as an INR of more than 1.5, not corrected by vitamin K, with clinical encephalopathy, or an INR of more than equal to 2, regardless of the presence and absence of clinical encephalopathy. So for easy understanding of all the residents over there joined in, whenever there's a liver failure, there should be no telltale signs of chronicity of the liver. Second, if the INR is more than 1.5 with encephalopathy, it is liver failure. When the INR is more than 2 with or without encephalopathy, it is liver failure. But when we are talking about an INR in these settings, we are talking about acute corrected INR. Corrected INR means that you have given vitamin K, 10 milligram IV, slow bolus over 2 doses, 6 hours apart, and then you see the INR, and if it is still more than what we are saying, we call them corrected INR. So corrected INR means whatever could be corrected by vitamin K. Any liver failure is that INR, which is hepatic based, means not dependent on vitamin K deficiency. So you correct the vitamin K deficiency, get to the corrected INR, and then start calling it whether it is acute liver failure or not. So when do we suspect? For example, a 7-year-old male child came to us with a history, short history. Day 1 fever started, low grade, no recurrence of fever after that, only low grade. Pain abdomen happened, which was also non-specific, mild, right upper quadrant, dull aching, no radiation, no aggravating factor, and anorexia. These 3 are typical prodromes. And after prodrome, once the jaundice appears, the fever goes away. In the natural history of acute viral hepatitis, until unless it is complicated by something else or a secondary infection, a secondary or a co-component infection as well. So this is a typical history which you will get in a child of acute liver failure, which are likely to be viral in etiology because they have a prodrome, low-grade fever, which subsides once the jaundice appears. Pain abdomen and anorexia is important. And then once the jaundice comes in, then we see how is the jaundice progressing. Is it progressive? Dark urine. So for this child, it was progressive. The urine became significantly dark, normal stool color, and no pruritus. That means it is essentially hepatic based, and there is no involvement majorly of the cholestatic injury. And then the child developed encephalopathy. So you see the jaundice onset to the encephalopathy onset is just 3 days. This is what is hyperacute liver failure. That means the JE interval, jaundice to encephalopathy interval, is less than 7 days and preceded by a prodrome. It's extremely important history and big thing to identify in the beginning. So encephalopathy was in the form of decreased interactiveness, irritability, combativeness, and not responding to verbal command. Combativeness means that when the child comes to the OPD or to the ER, he's shouting. And whenever we hear, a second opinion or somebody is trying to connect to us for such children, and we hear the sound, the child crying and howling, literally very aggressive, we already know this is grade 3 encephalopathy. So identifying combativeness in children is extremely important. So for this child, he was treated somewhere outside, managed his liver failure, intubated and advised for a liver transplant at our center and moved to our center. We took all this detailed history, which we said with the negative history, there was no additional history after the prodrome of previous intermittent fevers, no family history of contact, drug intake, any rashes or joint pain, increasing pallor, cola-colored urine, or recent change in handwriting and behavior. We'll come to each one of them after this. In the past history also, it was no previous history of jaundice. In the family history, there was no history of liver disease in the family, no history of autoimmune disorder, especially autoimmune thyroiditis. Celiac disease, they are very important to identify, and no history of neuropsychiatric illness, which happens because we want to rule out Wilson's. So in the family history, the child was second in birth order, non-consanguineous marriage. Though when we dig the history deep, they said there was a jaundice to the elder sibling 15 days back with prodrome, which resolved within 2 weeks. So that means even at a higher center, history is that very important. That they did not come out with that history before, but then when we took it came. No history of any other autoimmune disorder, no developmental delay, no abortions and SIP death. Birth and development history was normal. Immunization history specifically for A was not known. So when we examined this child, he was sick. He was intubated with a heart rate of 64, blood pressure 146/90, which was more than the 95th centile. Pupils were sluggish reacting, 5 millimeters. Icterus was present. However, we did not find any signs of stigmata of chronic liver disease. That means there was no cyanosis, no clubbing. On torchlight, it is important to look at KF-ring also if you're able to pick it up. If you're not able to pick it up, they'll go for the slit lamp. Otherwise, the anthropometry was okay. Liver was 3 centimeters below the costal margin. Span was 11 centimeters. It was a soft liver. Margins were not very well filled. Spleen was not palpable. So for abdomen also, there was no stigmata of chronic liver disease. The pupils were, I said, 5 millimeters, and the child was under sedation while intubated. The rest of the examination was all right. So this is what, when I was taking the history, this is what we find. That means there was a prodrome, then there was a jaundice, then there was a jaundice to encephalopathy interval of 3 days, which tells me that this is a hyperacute liver failure because encephalopathy has already come in. We had an outside corrected INR of 2.95 because they connected to us before we had already asked them to give vitamin K, and they put it as 2.95. That means this child is acute liver failure with advanced hepatic encephalopathy with raised ICT, which you see because of the bradycardia and the raised blood pressures which were present on examination. Hence, the child was referred to transplant. Now, when we go forward with these children, important learning points which I will go along is that, as we said, combativeness comes in grade 3. And in children, usually the early grade 1 and grade 2 are clubbed early, then the grade 3 and grade 4. So this is a modified assessment of encephalopathy in children, where the term advanced encephalopathy is used for 3 and 4. And mind you, the combativeness come in grade 3. So it's already late by the time the child is aggressive to us in the ER or in the OPD. What are the challenges with evaluation of encephalopathy in very small children? First of all, early stages may be non-specific. Second, in infants specifically, they come very, very late. And thirdly, especially in cases of infantile and neonatal ALF, we do not know the exact duration of illness. And when should we say, when did the encephalopathy start? That may not be very clear, unlike in this child. So these things we should know about encephalopathy. What are the warning signs in acute hepatitis whenever we're dealing with such cases? Deepening jaundice, excessive sleepiness, abnormal behavior, loss of appetite, persistent vomiting. Once or twice vomiting is not a red flag sign, but persistent vomiting is. Coagulopathy, bleeding from any side, abdominal distension, fever after the prodromal phase, seizures, cola-colored urine. There is a very common clinical entity which comes because enteric fever and hepatitis A and E have a common source of infection. Many times we see hepatitis A along with enteric fever. So if you have a child who persists to have high spiking fever and you know that hepatitis A or E has come positive, however, the child is still running fever, do look in for enteric fever because they have common sources of infection. Now, dilemmas to any center should be, will this child survive without a transplant? Are we giving him that window where his survival can be optimized and maximized? Or is the child showing signs that he will not recover spontaneously and we may have to move him only to a transplant unit or a liver unit where transplant is possible, to a liver unit where transplant is possible if needed? So the optimal window is extremely important. We should know what will maximize this regenerative capacity for this child and what will affect the outcome. So how we need to investigate and manage them at the same time. The common causes of ALF, when we are managing and evaluating, we need them. We should know their infections, A and E. They can be Wilson's. Very rarely we can have newer viruses, like newer in the sense they not be newer for a liver unit, but we have seen children now more so when they do come with EBV, CMV, parvo in specific settings. Definitely when they are with thalassemias, when they are with any other any other systemic illness, the identification of the non-hepatotropic viruses, atypical viruses are more. However, in the present scenario, at least in the first go, hepatitis A and E must be done. Ceruloplasmin must be done. A total IgG must be done because they are the top 3 causes: A, E, Wilson's, and autoimmune. The rest, paracetamol, ATT, valproate, and drugs, we know all of them, and these all must include must be a part of detailed history as well. So in the history and in the examination, the etiological pointers to me for prodrome is hepatitis A and E, viral hepatitis. Family history of contact is in favor of such causes. Whenever somebody has fever, loose stools, rash, red eyes, coryza, cough, lymphadenopathy, these are signs of atypical viral involvement. Many a times we see them in high volume units, but essentially you will not have rash, red eyes in hepatitis A and E. Wilson's, recent change in behavior, school performance, handwriting, increasing pallor, cola-colored urine because of intravascular hemolysis. Autoimmune hepatitis will have history of rash, joint pains, redness of eyes because of uveitis. Increasing pallor, cola-colored urine, again because of autoimmune hemolytic anemia. So both Wilson's and autoimmune can have hemolysis, but the difference is Wilson's will be a DCT negative hemolysis, autoimmune will be a DCT positive hemolysis. In autoimmune, the hemolysis happen because of autoantibodies, hence it is DCT positive. In Wilson's, the hemolysis happen because of free copper, and hence it is DCT negative. So these are very important basic concept which we all should know in ALF. Drug-induced injuries, we have to take out and rule the drugs if they were being taken. So as a baseline, LFT, KFT, INR, because you want to get the kidneys as well, but INR is very important, and we should start talking in terms of INR and not PT prolongation. INR is already a standardized form. Speak in terms of INR because the definition has INR. Apart from this, basic CBC, electrolytes, blood sugars, cultures, infections, blood group, blood ammonias, retics, DCT, and a bedside USG is important as the first baseline exam involvement. Along with that, the specific first line investigation should be to rule out hepatitis A and E. In specific conditions, hepatitis B, acute hepatitis B can be looked at. Wilson's disease, autoimmune hepatitis, and the second line goes atypical viral hepatitis and HLH, secondary HLH and others. But at least have the first line baseline and the first line specific etiological investigations done in the first row. In the lab of this child, when we saw that the corrected INR after vitamin K was 2.95, bilirubin was 20 direct, AST, ALT were 1600 and 1800, which are expected to be that. Alkaline phosphatase and GGT were normal. Protein and albumin, if you see the albumin is just 2.6. Now, some people may say that why is the albumin 2.6 in acute liver failure? So two things to remember. Though this child has a short history, but albumin is an acute phase reactant. So whenever there's an illness and because it's been an illness for him, he was treated outside and then came to us, it's been quite a long time for the child and they can have hyperalbuminemia. The half-life is only 21 days. Secondly, because of a negative acute phase reactant, if a child has overwhelming sepsis, acute liver failure having overwhelming sepsis, they can also have low albumin at that point. We should look at the clinical features, ultrasound features to actually identify whether they are CLD baseline or not. Look at the ammonia, 435, very high ammonia. Lactate was 8. And the other, there was no hemolysis. So by and large, I do feel till now that the child was acute viral hepatitis. We did HEV, IgM was positive. The rest all were negative. Look at ceruloplasmin of 18 in acute liver failure. Certain slightly lower ceruloplasmin can be expected until unless we do not have any other telltale signs. So this is what is a typical case where we have identified common etiology, we identified treatable etiologies, and we know, and we have to now, what is our job is to now optimize the regeneration of the liver and give the child that environment where the optimization will happen. So now when we start treating ALF, one thing is coagulopathy. Will I give FFP to a child of 2.95 INR? No. I will not give FFP until unless the child is actively bleeding or we are doing an invasive procedures. Whenever a child with ALF goes into sepsis and develops a secondary thrombocytopenia, they are likely to bleed because of thrombocytopenia and not directly because of the deranged INR. Because when the liver is involved, both the procoagulant and the anticoagulants are reduced together. When they are reduced together, the liver gets into a rebalanced hemostasis. That means anticoagulant and procoagulant both are less. So they have a rebalanced system. So they're not going to bleed until unless there is a super added DIC or we are doing invasive procedure where you are overwhelming the body system. And then only you need a cover of FFP or INR, FFP or platelet, depending on what is needful at that time. So this is what is very, very important to understand in coagulopathy. Sometimes when we have these children at INR of 6, 7, unrecordable INRs being transported from across the centers because the road transport does a lot of movement on the way. Very high INRs, we tell them to give one FFP transfusion immediately before the transport, because they will have very high risk of IC bleeds on the way because of the shear stress, and the movement on the road dysregulates the cerebral autoregulation. So hence these children get into a lot of IC bleeds as well, and also not just IC bleed, but also a lot of cerebral edema, which by the time they reach to a higher center, we possibly have lost them due to cerebral edema. So that should not be done. Blood sugar should be maintained slightly on the higher side. Among the fluid and electrolytes, we have to monitor the sodium, potassium, very, very important. We can keep sodium between 145 to 155, giving hypertonic saline. The earlier concept that we would give 70% of the IV fluid is not important. We sometimes have to give 100%. We also sometimes have to give every 6 hourly, and every 4 hourly we change according to the need. If the child had some other losses at some time, you have to maintain euvolemia. The earlier concept of dehydrating them so that the brain does not get cerebral edema does not stay, because if you keep the child underfilled, the cerebral perfusion will also reduce. The cerebral perfusion will reduce. That means the brain will have likely chances of more injury while during this liver failure. So you make sure that the cerebral perfusion pressure is maintained adequately so that the child will have better survival. We don't want tomorrow that the liver starts to improve, but the brain already had a hit and an irreversible cerebral edema, which was then life-threatening. And literally, there are some children we lose by the time they come to the center. The INR is only 3, but then the cerebral edema is irreversible. There's already coning. So that is very important, that make sure that there's no fluid overload. However, there's no fluid restriction also. And every 4 to 6 hourly, you'll have to monitor and input, output, and make sure that they are euvolemic. Among the infections, we always say that children who are treated outside at least for 5 days should be on a 1-step higher antibiotics before then they reach to the liver units. If they're already being treated with 5 days of IV antibiotics outside, it is prudent to start them on an antiviral, started with fluconazole. Why? Because acute liver failure is a immunoparalytic state. At that very moment, the child is immunoparalytic. He may not mount a response of fever. He may not even mount a response to high CRPs and high procals, because liver itself is a originator of all the proteins, the CRP and procal. So we always say that there would be some children who will have high, but there will be some children who will not have high CRP and progal, but they're still with sepsis. And please cover them with antibiotics and antifungals. Still, we rule out and all the cultures come negative. And usually in our country, where we realize that the liver failures are being treated at all the centers, it should not be following a guideline of the West where they say, okay, 3 days of antibiotic is stop. Our liver failures are being taken care at routine wards, routine ICUs. So be mindful of where we are treating. There is no harm in upgrading the antibiotic. Keep a low threshold for upgrading antibiotic, because we are going to lose the child if we lose that window of regeneration in the child. Whenever there is a raised ICP, especially grade 3, grade 4, we need elective intubations. By grade 2 to 3, we start deciding we have to intubate the child, because we want the brain to be preserved till we take care of the liver, till the liver regenerates. Some livers will have capacity to regenerate, but the child should not die of cerebral edema during that time. So it is important, the same measures which we all know, head in the midline, elevated 30 degrees, but practically happening on the bedside, all the staff to be very aware of. Minimal stimulation, bundle treatment, whatever you want to do to the child, do it at the same point and move them out. When the sisters and then the staff is doing that, giving a small bolus of propofol is good, so that by the time all the pricking is happening, that surge in raised ICT does not happen. There is no role of prophylactic anticonvulsant. So ideally, we would not give them not even levetiracetam. If at all, you have to give an anticonvulsant because you were thinking there was some subclinical seizures, you have an EEG finding, something related to that, then you may start a levetiracetam, but nothing else. Hypertonic saline and mannitol. Hypertonic saline is always the first one to be started. Mannitol should be given intermittently to take care of the surge of ICPs. Hyperventilation to make sure there is not severe hypocarbia as well, because we need to maintain if the PeCO2 is very, very low, then cerebral vasoconstriction happens and cerebral perfusion worsens. So a controlled hyperventilation can happen. Sedation and paralysis is extremely important. All our patients with liver failure, and just not ours, everybody in the liver units will be sedating them with both sedatives and even paralyzing them. So children are on fentanyl, atracurium, and propofol. Sometimes we use thiopentone for rapid surges in raised ICT because we know that if a child has an etiology like hepatitis C, which can be reversible, and it has now in liver units, it has a survival of maybe 60 to 70% without a transplant. And that too only the ones which are very high advanced hepatic encephalopathy. So it is very important to take care of the brain during all this time. Specific points, very pinpointed. If we have a neonate, use IV acyclovir until we have excluded. I will come back to this in the subsequent slide. Lactulose should be given. We should make sure the child passes 2 to 3 loose stools per day. Will lactulose improve survival? No, nobody is saying that it will improve survival, but will constipation worsen encephalopathy? Yes, it will worsen encephalopathy, and hence the child should have lactulose or any other laxative. Lactulose is still preferred, ensuring 2 to 3 soft stools per day. Rifaximin can be given because it is one of the anti-ammonia measures. What we should not be doing, do not overzealously give FFP. They cause trally, they cause overload, they cause no value until unless they're indicated. N-acetylcysteine can be given in early stage. We do give it even when the children come in late, but it should not be given in children less than 2 years because the studies which came initially for N-acetylcysteine had shown a poor outcome if used in children less than 2 years until unless they were paracetamol poisoning. So as an antidote of paracetamol, it should be used. However, without an antidote, it should not be used in children less than 2 years. Please avoid sedatives. Avoid hepatotoxic drugs and nephrotoxic. So midazolam is not the first choice of drug in majority of the liver units. We use propofol, fentanyl, and nitrocurine because of shorter half-life, shorter contact time, and we are able to assess the neurological outcomes whenever we need to see them intermittently. So for monitoring, we should have daily measurements of liver span. We already said INR, LFT, electrolytes, ABG, blood sugars you should be doing. Neurological monitoring is very important. Pupillary size. That I think ALF is the only place where where we don't trust the staff. When until unless the resident or us has seen the pupil size, we would not agree to it because that tells us a multitude of things. Monitoring for gastrointestinal bleeding, sepsis, and renal functions is important. Please keep a note of them. So when we come to the same question, which one will I treat first? So if I have a child where it is coming out to be Wilson's, I will start D-penicillamine. If there is a child who's coming out to be autoimmune hepatitis in this cohort of children, I will have an indication to start steroids cautiously, covered by antibiotics, and depending on many, many other things. We have NAC for paracetamol, and specific antivirals we have for hepatitis B, HSV, varicella, and CMV. However, for the rest, this is additional. For these patients also, whatever basic management guidelines have to go, they have to be followed. Now, a lot of hype is about plasma exchange, plasmapheresis, or we call it therapeutic plasma exchange, or CRRT. A paper came from King's College which said anybody having an ammonia, ALF with ammonia more than 150, start them on CRRT. Now, the thing is CRRT should be present somewhere. It is a good anti-ammonia measures. But what if we don't have CRRT at that center? What if initiation of CRRT, getting the catheters in time is going to be time consuming? So we have to understand that no machines are going to give survival to your patients. Machines are going to be useful at specific time points when done to the right patient at the right time. So the prognosis of ALF will not depend on how many interventions of plasma exchange or CRRTs would you do as a blanket treatment. Prognosis of ALF is only determined by the extent of the liver injury, by the etiology that it was, presence of cerebral edema and progression of cerebral edema, secondary infections, and development of multi-organ failure. Where in any specific child will you fit in a plasma exchange? You think it will be beneficial? The risk versus the benefit is the question that needs to be answered. And at present, they are only used as bridging therapy to either transplant or specific indications in medical management. When I say transplant, that means my donor workup is not ready. There is no way the child is going to survive without a transplant, but my donor workup is not ready. So what do I do to gain that time? That is where I pull in them to let the biochemical and even hemodynamic parameters slightly improve transiently. That's all, but they're transient. The specific indications for medical management in our scenarios would be very high autoantibodies titer in autoimmune hepatitis that are removed by plasmapheresis nicely. So if I have a specific conditions, I may touch upon a plasma exchange. G6PD deficiency related severe hyperbilirubinemia, because once the jaundice is more than 50, bilirubin is more than 50, my pigment nephropathy will happen and my kidney will take a hit. In these cases also, I can do a plasma exchange to remove the extra bilirubin. By the time I'll do 2-3 cycles, my kidney would have been preserved. And by the time the injury and hepatitis severity will also improve, and I can improve, the child will improve, and we will possibly save a kidney injury. Awaiting logistics for transplant, yes. Or whenever we have severe acute kidney injury in ALF, that is the places where we need to have. But please make sure we do not fancy these technologies just because we think some paper has said that you do it. There are indications, but there are indications where everything else is done appropriately because there was a logistic, there was a team of 50 people standing on one liver failure child. That is how things happen then. Please do not rush in to, give in extra sepsis, extra bleeding during line insertion for these, raised ICT happening during line insertion, and we losing the child. That is not what these therapies initially came for. Now, the big question would be, does any child require an LT? How do I know? Am I doing the right thing towards the child? Because my center doesn't have a transplant. If somebody thinks like this, am I doing okay holding the child here? I know they don't have the money to go to the higher center, but what to do, So the question is, will we only look at the prognostic scores? No. Prognostic scores are not the only thing. The most important thing is that we have to dynamically monitor the child. One specific thing I'd like to tell about the King's College criteria for the paracetamol was a good enough criteria which it came, and we still follow it. For the non-paracetamol induced acute liver failure, it was initially said when it came in 1989, it said it has a positive predictive value of 97%, but it was actually that cohort of patients were both adult and pediatric. When later in the year 2013, when the pediatric acute liver failure group took the data out of only children from that cohort of acute liver failure, they took only pediatric. They found that the positive predictive value is only 33%. That means children who today satisfy the King's College criteria and are given a poor prognosis, only 33% of them died without a transplant, that the rest recovered. That means there are more to recovery. And another important factor is that this study and all the cohort were in areas where viral hepatitis was not the most common. That means the A and E were not most common. In our country, we still have A and E. That means our survivability and our spontaneous regeneration of the liver, if given adequate logistic care during that acute phase, is much higher. So just because somebody fills in a KCC criteria and they refuse to go to a transplant center because they do not have the logistics, we should not stop our medical management. Try and save each child. You will be surprised to see how beautifully children come out. The sickest of the children will also come out. So unfortunately, still in acute liver failure, we do not have an ideal prognostic score. We just have to see that I should not allow the child to die, but I should give the maximum survival environment to the child, and I should be able to identify when he is not going to survive with native liver. This is very important. So what do we use? Everybody uses a common sense approach in hepatology. It is an interplay between INR, bilirubin, is it increasing, LFTs, encephalopathy, out of which INR and encephalopathy are the most important. And keep monitoring, redoing, and assessing the child every day. Another important part, it should not be complete before I say the preparedness, because India is a predominantly living donor related transplant. So if the family has donor, if the family have financial logistic, or they arrange a financial logistic, or the center arrange a financial logistic for them, we still need to move them to that center. Not every pediatric liver failure is being catered at the pediatric liver center. They are being catered at general centers as well. So unlike the Western world, where The moment it is ALF, they are streamed up to the highest center. And because it is a disease donor, the moment they get a liver, they give the liver to the child. Our country still needs a referral to a pediatric liver center, start donor workup. Initially, if we feel that the child is not going to make it, we will start the donor workup, keep it ready, closely monitor, see for 1, 2, 3 days, and then only go for a LT if there is no improvement or there is worsening. This is what we need to learn in our settings, that identification of ALF and moving them up early, whether they are going to survive without transplant or with transplant is not a criteria to move them to a higher center. They should be moved to the higher center, because the higher center where people are not doing other things, people are not managing meningitis, people are not managing other things, and only liver unit, they are going to have more manpower to handle these children. That's the only thing. Now, when we come back to this case, so this child, so we knew that he had coagulopathy, he had encephalopathy, and raised ICP despite continuous infusion of fentanyl, high dosing etracurium, as well as propofol. The child continued to have very high raised ICT, and saving the liver became very important, even though we knew that hepatitis A, E will have a finite injury and will give some window to us. So he was continued in ventilation, the CVP line was inserted, a target mean arterial pressure was maintained, and IV fluids were maintained according to what it was. For us at that time, somewhere around 90% of the maintenance were coming by the time we could stabilize the child. NG feeds were started on a normal calorie, high protein of 1.5 grams per kg per day. In ALF, we will give them because we're taking care of ammonia by many other ways. The blood glucose were maintained, broad spectrum antibiotics was given, and vitamin K was also given intermittently, because definitely they will be into deficiencies. Now, so this is what happened to the pupil size, which started from 5 to gradually increase the first day to 6 and then came down. We also have optic nerve sheath diameter, which many centers have now started doing. It is a very good thing, which was also very high, and in cutoff values where we say once it is more than 4.5 in children, it shows a poor prognosis. But that is how life is. The more we handle systems, we know that there would be children where outcome will be better, because we know the etiology is not that bad. So the child required supportive measures in terms of hypertonic saline continuous infusion. We had to give intermittent mannitol. Propofol infusions we had to give intermittently. We also gave the child thiopentone at 2 major points where we thought that the refractory ICT is it's very bad, and the child may just cone at any time. But whenever thiopentone is started in these children, they suddenly develop hypotension. So you should be ready with increasing your inotropes, or if the child is not on inotrope, starting of inotropes immediately at that time, because it causes a lot of hypotension suddenly the moment infusion starts. So once we have the child intubated with us for 7 days, the condition improved. He drew a Klebsiella, which was taken care of. And then you realize, look at the way ammonia, lactate, INR trends are. This is what we need every liver failure child to be able to, given the time, so that the brain is saved till the liver shows this. So the brain, if would have a coning at day 1, we would not see what happens in day 6. So see, the ammonia came down from 435 to 223 and down to 84. Lactates came down, INR came down. That means the liver has regenerated now. So the take-home messages, especially for ALF, I would say, pediatric ALF, viral hepatitis still remains the most common cause. Close neurological monitoring is extremely important. Try to detect early encephalopathy. Manage the raised ICT at a very early age. Electively ventilate the child once they reach grade 3. Careful transport to a referral pediatric liver unit. Don't scare them that now the only way of survival is transplant. Just say, go to a liver center, whichever is near your place, whichever is near your territory. It's more than enough. Please refer them early. Avoid unnecessary use of FFP. Whenever there's a rapid clinical deterioration, please send a referral early and facilitate the movement. Don't put the patients, go there and come there. Try to use the resources. As doctors, we are very resourceful people. The patient is not as resourceful as us. Call up your networking, call up your doctors, call up your friends in different hospitals which have liver unit, and tell them, okay, this is the child. get your team on this child and get the child shifted. So this is the child which we received, like the first one, managed, and finally we pulled him without a transplant. It is worth doing when medical management is done. Not every child would be as as lucky, but then the ones who we know would not make it without transplant, they would be transplanted. But the question remains, post-transplant also, the life has to be beautiful. And we are doing the transplant at the right time for the right child. So when I conclude it, transplantation should be taken only as a last resort. It replaces the original disease with a new disease and risk. However, that was the only way of life saving at that time. And hence the decision to whether go for transplant in liver failures lies solely with the communication of the the liver team with the patient. Do the transplant for the right reasons and at the right time, and always try and save the native liver. Children will be saved much more with native liver as compared to adults, and not every ALF needs transplants. Many can still be salvaged without LT. And with this, I close the pediatric acute liver failure, and I will quickly go through the neonatal liver failure. So unlike the pediatric acute liver failure, which this is the definition we did earlier, neonatal says I'm little different. Why do they say I'm different? Because they say my etiologies are different. I have more of neonatal hemochromatosis. I have more of GALT. I am more of viral like HSV. I have HLH, very important, both primaries, majorly primary HLH in them. I have a very important segment like mitochondrial encephalopathy, which is a Pandora box in itself. I have metabolic liver diseases apart from mitochondrial, like tyrosinemias, and I have many indeterminate causes because science is evolving. So that is why newborn liver is different. Also, because birth is the earliest time at which signs and symptoms of liver failure can be observed. All the neonatal liver failure are considered to be acute by definition, even if cirrhotic. That means the prototype of neonatal liver failure, which is the gestational alloimmune disease, actually that liver is cirrhotic. But despite that cirrhotic liver, it is called acute liver failure because that is the earliest time a child will present to us. Third thing they say is that INR of a normal newborn extends up to 2, and the normal premature newborn may have an INR more than 2. So what is abnormal is then is they have reset the value and say neonatal liver failure usually is considered when the INR is more than 3. Now, depending on whether the newborn was a full term or premature and how many days the child is post-transplant, how many days the child is post-birth now, will we pick up this definition? But please don't make sure that 1.9 is a liver failure. 1.9 is no liver failure in neonates. And the fourth thing it says is that for neonatal liver failure, encephalopathy is not one of the required things. We need not have encephalopathy to define somebody as neonatal acute liver failure. If we know this basic concept, everything will become very clear, and at least we would be able to do the initial workup, majority of the workup at whichever peripheral place you live in. It doesn't really matter. All of us are similarly trained, almost similarly trained in pediatrics. We all know how to look at newborns and children. It's only that the conceptual thing is one probably I would like to give in through this webinar. So when the children who were young infants, sometimes the young and neonatal in some of the studies they've built in together, like till 1 year of age or neonatal, they always said that what do I have? Like for this study, they have taken all infants less than 90 days, that means 3 months of age. They found that the common etiologies were indeterminate, metabolic, neonatal hemochromatosis. Now, depending on different studies, which part of the world they are, they will hover around metabolic, neonatal hemochromatosis, and indeterminate. Spontaneous survival is slightly lesser as compared to the pediatric acute liver failure. Liver transplant would be done in major centers outside as well. Apart from that, indeterminate is a major etiology for them, possibly because of many genetic factors and metabolic diseases which are not able to identify in that early narrow window. So this was a landmark paper from neonatal liver failure on neonatal liver failure. It also mentioned that when we say a newborn, less than 30 days, neonatal hemochromatosis becomes the most important. Once is more than 1 month, metabolic, other viral, HLH, they become. So it's an interplay of these 3-4 causes which come to them. In this also, from data from the King's College, they said neonatal hemochromatosis is the most common, followed by HSV, enterovirus, galactosemia, and many other etiologies.
Dr. Arti, please conclude.
Yes, just another 5 minutes I'll conclude. So in the liver failure diseases, congenital infections are there, gestational alloimmune disease is there, and the others we know. Again, similarly, when you say, we should also know that neonatal hemochromatosis and gestational alloimmune disease is not the same. They are not synonymous. However, neonatal hemochromatosis is the most common single disease etiology of neonatal liver failure. That still remains true. What is the pathophysiology? We have alloimmune injury to the nascent hepatocytes. They go and injure the fetal liver. From there, that fetal liver accumulates that injury, starts having tubulogenesis and fibrosis in the fetal life. That is why when they are born, it's a neonatal ALF with cirrhosis. And we say that it's congenital and familial, the GALD. However, it is not genetic or hereditary because it is by birth familial in few families, but it is not a genetic or hereditary disease. It is a prototype of fetal liver disease that extends from the newborn to produce a liver failure. How do we manage them? Clinically, we may have a history that the mother lost few. If it is the primary, we may not have the history. Antenatally, some of them will have IUGR, oligohydramnios, premature births. We will have neonatal liver failures within hours. Sometimes they come by the time they come to the to the healthcare unit. There may be few days to weeks, and they will come with multi-organ failure, hyperglycemia, marked coagulopathy, hypoalbuminemia, edema, oliguria, and sometimes non-immune hydrops as well in these patients. So if we have a neonatal liver failure, first we definitely should think of gestational alloimmune disease. We should look for extrahepatic cirrhosis. We all know in the pancreas, in salivary glands that we pick up. The laboratory findings, which are very important, is that the AST-ALT are disproportionately low for the degree of hepatic injury that they have. So the enzyme level, the AST-ALT are very low. Alpha-fetoprotein is very high. Ferritin is also very high. The important thing is sometimes we do a staining C5b9 for gestational alloimmune, but it is not specific for it and it can be seen in multiple others. When do you suspect? You suspect GALD when there was a liver disease antenatally or very shortly after birth. Unexplained cases of death or a newborn death. Diagnosis is done with demonstration of extrahepatic cirrhosis in the T2 weighted MRI or the biopsy of the oral mucosa. This is what the T2 MRI weighted MRI and the biopsy of the buccal mucosa that we do. Sometimes, of course, we will have HSV, which will have very, very, very high AST-ALT, very fulminant. That is why we have very, very high AST-ALT. We should start acyclovir in the neonatal liver failure. CMV, on the other hand, will not have that high ALF, that high AST-ALT. The prognosis and progression of ALF is not very fast in them. And we should identify them by the serologies and the PCMs. Just the last 2 slides. Differential diagnosis of neonatal ALF, gestational alloimmune disease, viral infections in which HSV is most important, HLH, primary and secondary both, primary more, and mitochondrial hepatopathies. This looks like a busy slide, but I'll make it simplified. In neonatal hemochromatosis or the gestational alloimmune disease, we have very high bilirubin. Transaminases is not very high, but coagulopathy is severe because it was a cirrhotic liver. In HSV, transaminases were very high. In HLH, hemophagocytosis, cytopenias will be there. Additionally, ferritin it will also be very high, like the NH. But you will have significant cytopenias, and you will have to rule out neonatal hemochromatosis in the cases which you will identify as HLH. And of course, there are cases of mitochondrial metabolic liver disease, which will have multitude of presentations. So this is a proposed algorithm. Whenever you see a neonatal liver failure, start empirical acyclovir, evaluate for all causes, look carefully for gestational autoimmune disease and important biopsies and go accordingly. And in case it is HSV, cyclovir does really good wonders, and majority of the children will improve. So the summary of neonatal ALF is the outcome for neonatal ALF is poor as compared to the pediatric counterparts for us. Viral infections and gestational autoimmune disease are the most common etiologies of neonatal ALF, in contrast to the metabolic and genetic causes as the leading cause of neonatal ALF in older infants. Significantly elevated aminotransferases on presentation indicate a viral hepatitis, and coagulopathy with low aminotransferases favor a gestational autoimmune or the neonatal hemochromatosis protocol. Despite medical therapy, native liver survival was low for neonatal liver failure. However, there has been incidence of liver transplantation also done, which is now gradually improving.
Thank you, Dr. Arti. I think we have the shortage of time. We can conclude here.
Yeah, this was my last slide. Thank you very much.
President, kindly take the valuable input from the chair.
Thank you, Dr. Arti, for a wonderful presentation. Please stop sharing your screen. Thank you. Any comments?
Thank you, Dr. Arti. Wonderful session. And over to Dr. Meena.
Before taking the question answer from our delegates, I would like to take the few comments from the chairperson sides.
It was a very wonderful session. I think without wasting time, we should take the question answers better. Otherwise, the time is running short. And Dr. Aarti has very well explained when to go for the liver transplant. Many cases, like she very well said, that in India, we don't have that much of this thing that every patient we can refer as in the West for liver transplant. We should try to manage. And there is a very fine line to go for LT or to medically manage, and very well explained by ma'am. Thank you, Dr. Aarti. It was a wonderful session.
Your side, any comments? Comments from the Simarani ma'am side?
I think she is not there, so we can start with the question answer.
Okay. We have the expert Dr. Karnes here. So just a first question for our expert. For the biochemical liver injury, does any cutoff for the bilirubin and liver enzyme in the defining criteria? Dr. Karnes, are you there?
Yes. Yeah.
The audience.
So
no.
So biochemical injury, any raised AST/ALT would be sufficient. Like Dr. Arti mentioned that in some of neonatal liver failure, you may have a pretty normal AST/ALT. So always keep in mind in some conditions it will be very high, some conditions it will be normal. So there is no criteria as such, but there should be some feature of liver dysfunction either.
Okay, sir. Okay. Then other one participant asking, does any age-specific vitamin K dose or all the recommend like the Dr. Arti said 10 mg per day for the 3 consecutive days, then repeat the INR. So, Doctor, hello. Does any age-specific dose for the vitamin K or just blindly give the 10 mg per kg in the whole age group?
So normally what we practice is that 0.2 milligram per kg because that is extrapolation from the 10 milligram stat dose from the adult data. But I don't know, it could vary center to center. I don't think there is any recommendation as such age appropriate dosing of vitamin K.
So usually we are doing the practice less than 1 year of age, 2 mg per kg for 2 mg per day for 3 days, then 1 to 5 year for 5 mg per dose for 3 days, then above the 5 year 10 mg. The other one is asking which one the condition in infant lead to rise the transaminitis, need careful observation rather than transplant or move on it. Dr. Arti already covered about that. Other one is asking how can we differentiate the hypoxic related injury or drug induced liver injury in the cases we brought in the casualty as a acute seizure or known case of the seizure disorder and brought in the emergency with transaminitis and history of the anti-epileptic drug. So how can we differentiate the transaminitis is contributed by the drugs or the transaminity contributed by the hypoxic injury?
I think my opinion in this regard would be just a very tricky question. But yes, if valproate has been given to the child for a very period of time, so probably we should not expect valproate toxicity in that scenario. So we'll have to think in terms of other drugs or hypoxic injury, because hypoxic injury will have a very rapid rise and a very rapid improvement also. Dr. Meena, do you have any different
Yeah,
opinion regarding this?
definitely you rightly said, if you are the suspecting hypoxia associated transaminitic, that rapidly rise. Once you restore the perfusion, they rapidly fall. In the drug-induced liver injury, the transaminitis might be 5 to 10 times, but not more than 10 times. In the hypoxia injury, the transaminitis is significantly high, like the 5,000, 10,000. Once you restore the perfusion, then transaminitis rapidly fall. But that is not happened in the drug-induced hepatitis.
Yes. And just to just
Yes.
in continuation of another question, any rise in AST/ALT is significant. Just we don't always try to make it 3 times, 5 times. These are not the criteria we use in liver injury. That is true for pancreatitis and some other conditions, but not in the liver. Any rise should be considered as some insult happening in the liver and needs to be monitored depending on the child's condition.
Yes. Dr. Anjali, any query from your side, because you are belong from the Punjab side and we have the lot of the cases
Yeah.
in just like the
I just wanted to add that last year we had this hepatitis, prolonged hepatitis phase. Last year we saw so many patients. Definitely, some of them were coming with Hep A or E positive, but others were even not coming positive. They were having, all were having very high transaminitis, 2500, 2200, like this, with the bilirubin of 18 to 20. But somehow we were able to manage in our government setup, to all of them, to with the medical management. And one thing I would like to say, and in these cases what I have seen is NAC infusion was very helpful in keeping them away from going to the hepatic encephalopathy. What is your say, Dr. Arti?
So, NAC will be used if they have liver failures. But were those children having an INR in the range of a liver failure, the ones which you had bilirubin 20 and these?
No. INR was not more than 2.
Yeah, so see, anyways, why I was saying hepatitis A and E, between the A and E, A is the one which also can has propensity for cholangiocytes. So those prolonged hepatitis that you are saying with high bilirubins, many of the time it is a prodromal, it is the prolonged cholestasis phase of hepatitis A. But because sometimes they have by 6 to 8 weeks, by the time they come to us, their IgM is going down and IgG is coming up. We sometimes have HAV IgM negative. However, until unless they are ALF in the definition, NAC has no role. NAC has no role in acute hepatitis. It has role in acute liver failure, not to be given less than 2 years, even if it is acute liver failure. Otherwise, NAC will not. NAC does not itself change anything. No survival. Rather, in the study, it did not say that the ones who were given in liver failures, only in the early phases they were given, they did not worsen the survival. It never said that it improved survival. So the studies which are coming are not somebody which say I improve the survival, but I would rather say that we should go back and look at these cases and do their HAV IgG, go back to the history and see whether at some time they were those.
Okay. Thank you.
Okay, Dr. Arti, I just request to just give the very crispy reply, because we have the running very shortest time and I have the few queries that are important explanations should be come from your mouth. That you said in the history you should look the important thing like the warning sign the acute hepatitis. What is the message you highlight the fever after prodrome fever? What is the significance in the one line?
Either added on super added infections like bacteremia brewing or something that enteric which started initially but we missed. Secondary HLH, many of the ALF will go into secondary HLH, they will also start mounting fever. So try and understand why this fever is there. because there is other second etiology than the standard ALF.
Here, normally in the prodrome, usually fever once gone, then jaundice come. So usually
Yes.
fever persists for 24 to 48 hours,
Yes.
not more than 3 hours, 3 days. But in the tropical causes of the other causes of the hepatopathy, like the dengue or like the enteric fever, like the other concurrent infection, if the child have the prodrome-like feature, but fever is continuous going on, along that other findings, we should rule out the other concurrent infections before taking any final.
Definitely. Any concurrent infection should be come. We should not say that in our country, malaria and dengue will never hit these children
Yes,
while they're having a prodrome of hepatitis A. It
As a
can.
being pediatrician, we know many cases referred from the periphery, they have the like the viral like illness, but jaundice increase after some of the medicines. That likely, I just want to give the message to Dr. Anjali. Those are the G6PD deficient kids. If you are giving the vitamin K in the acute viral hepatitis, that are intravascular hemolysis that increase that cause the rising of the bilirubin. So in that situation, we should, as a being pediatrician, we should aware in children's don't give the blindly repetitive vitamin K, especially those are the kids have the double digit bilirubin along with anemia, just like the single digit hemoglobin, because there's a high possibility of G6PD, especially in the G6PD deficiency of the intravascular hemolysis, so no splenomegaly, bilirubin in double digit and hemoglobin in single digit. There is just as a being pediatrician, we should aware about that. And in the history, we should look cola color urine. As Dr. Arti rightly said, in the history, we should include the or question, does have the child have the any dark color urine along with cola color urine. If the child have the history of cola color urine, that means intravascular hemolysis might be due to the copper related or might be due to the G6PD deficiency. In that situation, better to take the call for the G6PD level rather than giving the blindly repetitive vitamin K. And the other things for the pediatrician, the over prescription of the antibiotic, especially in the children have the jaundice or especially like the nowadays we are the unnecessary prescribe the clavulanic acid. So better to avoid the use of the clavulanic acid, especially in the milder infection. Better just prescribe the amoxicillin rather than amoxiclavulanic acid or azithromycin that might be cause the drug-induced hepatitis. In the investigation, you said in the your PowerPoint presentation, the first line investigation you should must be include Wilson workup, AIS workup. Should we go blindly trust on that statement or should we filter according to whatever we get the clue by the stand examination?
No, we will
Because in the
definitely filter. Yes.
resources
will-
limiting setting as well as reliability of these parameters in the acute liver injury is very not a fully rely on that.
No, so we should be very closely. This all will come once we've taken the history. On the basis of history, what we have and what is available to us. But as a approach to the child, we know that even if we say if a child is coming out to be A&E negative, but still having viral hepatitis, sending a total IgG. Once the child comes to you, once the child comes with you to the reports, the basic reports, sending an total IgG and sending the serum cellular plasmin is going to help you in this subset. We are now looking at not children who did not come with liver failure. We're looking at children who came with liver failure. Among them, the reproducibility is high. So we should
here
know
is the
whether
message
we're talking about a pediatric OPD or we have already identified a cohort. It is among that cohort.
Okay. So we should take the very carefully because
Yes.
seroplasmin might be low in the feliciously in the acute significant hepatic parenchymal loss or autoimmune viral marker may be feliciously positive in the ALF. So don't blindly rely. You should correlate clinically as well as other relevant parameters. Important thing, history and examination. And the about the management of the ALF. You said the FFP only indicated in the child have the significant GI bleed or whatever external bleed or invasive procedure. Does all invasive procedure we should recommended the FFP? First of all, the very clear-cut message from the Dr. Arti mouth that don't give the unnecessary FFP transfusion in the children have the coagulopathy in the ALF. It might be create the problem rather than the benefit. But if you are planning to invasive procedure, then the all invasive procedures should be give the FFP. I am talking about the context of the ascitic test.
No. See, a sighted tap is not that an invasive procedure. By invasive we mean putting a dialysis catheter in place,
Exactly,
and that
clear,
too,
clear-cut message is a high invasive procedure, like
procedures.
the
Yes.
central line insertion, liver biopsy, other any deep invasive of procedure only recommended the FAP. You rightly said about the fluid and electrolytes as well as blood sugar monitoring. Still, many pediatricians prescribe the D10 fluid in the ALF cases. What about it?
No, see, we should understand that depending on how much, what is the sodium, what sodium you want to correct, what has been the losses, what is the potassium, we pick and choose the IV fluid. It is not a standard IV fluid. So basically, what is important is that because the IV fluid rate will change frequently, and we also want a high blood sugar, the blood sugar to be maintained. Essentially, they are run on a separate dextrose infusion, be it D10, be it sometimes 12.5, be it sometimes 25, just to maintain that blood sugar. And on this side, the IV fluid has, most of the time for us, it is cabilite, or it is sometimes normal saline with added potassium in it. But we try to keep the dextrose line and the IV fluid separately. Just increasing the DNS because the sugars were coming down, it is not something which is advisable for these. Hypotonic solutions should not be used in any of the ALFs because they worsen the stability. I think Dr. Sham's piece. And Dr. Anjali?
I think
Yeah.
any more questions?
Dr. Sham, I think on the network issue create हो गया.
There is another question.
Yes, ma'am.
Role of L-ornithine and L-aspartate. We have discussed, I think.
So there is no clear-cut role of L-ornithine or aspartate. We essentially have now stopped using them. They will have no survival benefit. We should know that what is more important is hemodynamic and euvolemia and euglycemia and preservation of raised ICT. They have no survival benefit. Will I say that they will worsen it? Not really. They may not worsen in ALF, but they have no standalone survival benefit to liver failures. What is important is the child should be passing 2 to 3 times loose stools, soft stools, by the use of lactulose, which is important. That is important in liver failure.
Any special diet in the recovery phase?
No special. We always say that keep them high calorie, which is important. Protein, don't be very scared of the protein. 1 to 1.5 grams can be given. It all depends on if you're able to remove the ammonia. If the center is not able to come little down, be 0.8 gram per kg. But energy the calories has no restriction to it. Keep a standard high calorie NG feed to the child. It will help the child recover.
Thank you, ma'am. And I think there's no more questions. And Dr. Sham connection is as lost also. So, any comment from the president, sir, Dr. Ajay Gupta, sir? Yes.
So once again, thank you, Dr. Arti, Dr. Anjali, Dr. Karunesh, and
Yes.
Shamina. It was a wonderful discussion and session. Please continue.
Now, okay. Now I would request our Treasurer cum Secretary-elect Dr. Ravindra Kumar to put vote of thanks for the faculty and delegates.
Thank you,
Over to
Dr.
Dr. Ravinder. Yes.
Thank you, dear Dinesh. Thank you very much. Thank you, Dr. Ajay. Wonderful session, Dr. Arti, Dr. Anjali, Dr. Karunesh. Every week, every Sunday, I think I'm learning more and more gastroenterology. And I think after a couple of weeks, I will become a gastroenterologist rather than endocrinologist. I hope the same, my all delegates must be learning all this. So thank you all, and thank you all the delegates, because on every Sunday, 9 a.m., I think I'm in more than 100 gathering. Kudos to all of them. Even sometimes I find difficult because presently I'm at Trivandrum for my some endocrine meet, and but every weekend I have seen so many delegates. A couple of very good points have raised by Dr. Shamina also. Just one query to Dr. Arti and Dr. Karunesh. Actually, he mentioned about this quinolinic acid. Nowadays, I hardly find a case in my OPD who is having one fever and has not been given this moxie plus clavulanic acid combination. Although I'm working in a government hospital, but I don't know why this is happening. Most of the time it happens. Although luckily I have not seen any liver failure, or as he's saying, it is a very. So, is there any dose related? Because in pediatrics, everything is a dose related. Most of the time, it is just 75 or 150 milligram of clavulanic acid along with the amoxicillin. So, your just one query, the one comment, your expert, because this you must be encountering in your daily practice.
So clavulanic acid is essentially a cholestatic injury. It does not lead to liver failure per se. So, and it is an idiosyncratic injury. It cases of clavulanic acid causing liver failure would not be there. Causing drug-induced cholestatic pattern of liver injury are there. But the question is, because we can sometimes avoid a clavulanic acid and give plain amox. That's why this concept came up, that between the two, clavulanic increases it. So why give it unnecessary?
Hey, that is okay. Thank you. I already obviously
And
it should
and
be there. Just
and one
make
more pointer. Sometimes, if the child has some viral infection, like adeno, entero, they can cause liver failure. So sometimes, if you have given this clavulanic acid, then probably it's sometimes really difficult to find out whether the virus itself has caused the liver injury or it's clavulanic acid per se. So that's why we have to be very careful. So it could
okay. Is
be
there any
sometimes, I
dose
don't.
related? This was my query, was that any dose relation is present?
As Dr. Arti just mentioned, it's most of the time idiosyncratic reactions, so may not have any dose correlation, but we are not aware of any dose correlation per se.
Thank you. Thank you very much. Thank you all. Thank you, Dr. Dinesh, Dr. Ajay, Dr. Meena, although his connection is lost, Dr. Anjali, Dr. Dr. Arti, and most importantly, all of my delegates. Thank you all of.
Thank you, sir. Thank you.